All right, good afternoon, everyone, and welcome to our final day of Inclusive Excellence Week for this 2024 year. Really excited for this fifth day for us to focus on geriatric dental care, which I think is an often forgotten aspect of when we think about health equity, when we think about diversity, when we think about inclusion in terms of really the ageism that either we might face in society broadly or that our patients may face or that we may subconsciously take on ourselves when we're thinking about treatment recommendations that we recommend for patients, like how much the age of our patient is influencing what we offer them, right? So I'm really excited for our speaker that we have today, Dr. Christie Hogue, who I've known actually since we were both in dental school. I was at Michigan, she was at Howard, but we were both very active in SNDA. So it's great to see her being at the top of the game almost 20 years later. She is a dentist, author, researcher, and host of an educational podcast called Aging Pearls. As a sought-after speaker, author, and educator, she's best known for designing training curricula for medical residents, geriatric and hospice and palliative care fellows at many of the nation's top academic medical institutions. She is an American Geriatrics Society Fellow, and as a dental geriatrician, she has developed a unique perspective of the correlation between oral and systemic health. After completing an advanced fellowship in geriatrics, she has become one of a few geriatric-trained hospital dentists around the country. With nearly 2 decades of service, she has distinguished herself among colleagues and established a national reputation as an expert in the field. She is competent in treating the needs of functionally independent adults, frail elderly, and functionally dependent elderly. She has experience in rendering services to community-dwelling homebound older adults, as well as residents of long-term care facilities. The correlation between oral and systemic health is prevalent. There's a need for increased awareness as well as collaborative approach to treatment and overall safety of patients. She has held faculty appointments at the University of Miami, University of Florida College of Dentistry, and Emory University School of Medicine in their Division of Geriatrics and Gerontology. She holds advanced degrees from both Tennessee State University and Howard University College of Dentistry. So it's my pleasure to introduce you to Dr. Christie Hogue today.
Good afternoon, everyone. How are you doing? I ask that you please bear with me. I'm sorry, I have a slight cold. I'm just going to push through one for my little one. But today, I thank you so much, Carlos, for having me. Here. I'm very grateful to be here to speak with the University of Virginia community. So today we're going to talk about advancing health equity and geriatric dental care. Just want to make sure that everyone is able to hear me.
You're going in and out just a little bit. I don't know if you have like headphones, but sometimes it's clearer than others.
Okay. Are you able to hear me a little clearer now?
Yes, that's better.
Okay, so I'll just continue to lean in. So we're going to just go over a few topics. It's a broad spanning topic, but I'm going to try to bring it all together as it relates to looking for the health equity of our older population. So we want to understand oral health disparities as it relates to geriatric patients, identify the need for cultural competence and inclusive language when treating geriatric patients, and also the importance of interprofessional communication when it comes to treating our geriatric patients. So when it comes to the importance of oral health for geriatric patients, we want to maintain their oral health is critical for their overall health and their quality of life, because we know that a lot of the oral health plays a role in the systemic health of our older population. When it comes to oral hygiene, basic dental decay, root caries is more prevalent, gum disease, and tooth loss is not inevitable, but with poor oral hygiene, it does happen. But I just want to stress the fact that just because you're older doesn't mean that you. So understanding geriatric dental care, you have to understand the unique oral health needs of this population where we're dealing with stomia, gingival recession, which can lead to the root caries and also some patients that have oral cancer. There is an important need for the comprehensive assessment to address the oral health concerns, an interdisciplinary approach, which we're going to speak on in a little more detail further down in the presentation, and the preventative measures, such as the fluoride trays, the silver diamine fluoride for those who are not able to get full care, um, and also to further prevent complications. We want to use adaptable treatment plans for some of our patients that may be physically or cognitively impaired. There are different treatment modalities that you want to adapt for those patients. Now, there are several barriers that geriatric patients may encompass, such as limited mobility and transportation. A lot of times there's lack of access to transportation for getting the patients, maybe homebound or in a long-term care facility. They have to be transferred in a stretcher. Some of the financial constraints, of course, is the cost of dental care and the lack of insurance, the lack of coverage through Medicaid. The issues with the cognitive and physical impairments. Um, it's important to get the right parameters when you're dealing with patients with cognitive issues such as dementia, Alzheimer's disease, and also those that have the physical challenges. It's important, even with those patients that are not able to maintain their own oral health, to have a healthcare champion, especially in long-term care facilities, aid these patients in maintaining their good oral health. And the dental providers or hygienists can kind of step in as it relates to those patients that don't have access to getting to the dentist per se. There's also a shortage in dental professionals that are actually trained in the specialized care for geriatric patients. So there's a need for more geriatric fellowship trained dentists. And then when you're looking at another barrier is the patients that may have fear and anxiety and don't necessarily want to go to the dentist due to trauma or past negative experiences that they have. Now, when we talk about health equity, the World Health Organization has defined it as the absence of unfair, avoidable, and remedial differences in health status among groups of people. Health equity is achieved when everyone can attain their full potential for health and well-being. When we look at equity versus equality versus disparities, it's important to understand that equality is when, for instance, oral health equality implies when the existence of oral health, of equal oral health attributes to among different groups. But for equity, you're looking at oral health equity. This incorporates the ethical quality of a equality or disparity. So, for instance, a person, you may have the example that the burden of dental caries on non-Hispanic Blacks compared to non-Hispanic whites. This is just a statement of a disparity. However, when you make the ethical question stating the above, disparity is unacceptable or that it should be eliminated or reduced, then we're taking a stance on the need for health equity. So we know that in 2000, our Surgeon General David Satcher made the stance that the status of the unmet needs of vulnerable populations is a silent epidemic. So oral diseases can severely affect their systemic health, and especially with our older population, there are correlations with diabetes, with respiratory issues, and with the mental health status. Some patients may be experiencing depression and have the lack or the motivation to maintain their oral care. Um, Also, preventable diseases, excuse me, and their profound disparities in oral health and access to care for all age groups. But of course, right now we're focusing on our older population. So, according to the CDC, oral health disparities among older adults are complete tooth loss with more than 3 times as common among the older adults who have less than a higher high school education compared with those who have more education. And that's basically with the health literacy. Patients that have complete loss more than twice common older adults with low income status due to smoking compared to those with a higher income status that never smoked, and untreated cavities were more common in non-Hispanic Black populations and more than twice as common as Mexican and older adults. and this can be found on the CDC website. Factors that contribute to health disparities include systemic racism, discrimination, poverty, and limited access to quality health care. And as we know, with health disparities, we cannot leave out the socio determinants of health, such as economic stability, um, education or access to quality, social community context, neighborhoods, and also the healthcare access to this quality of healthcare. So how does this play into the social determinants of health for those who may have a lower income or um, don't have the resources in their household? This impacts their ability to afford basic essential household needs in addition to healthcare. Um, those who have a lower education level, they have maybe less job opportunities or health literacy to have insurance, to have access to the healthcare. Housing instability, of course, transportation and getting to and from the dental appointments, social inclusion, those who may be not socially connected, and then access to healthcare as a whole. When we look at cultural competence, we want to understand that the cultural influences the health behaviors and preferences for healthcare. So when we are treating our patients, we want to make sure that we're respectful and communicating with them and taking into account their cultural background. When we're looking at cultural awareness, it's very important. This was just a schematic on the process of cultural competence that was brought up. And when we look at cultural awareness, it's a process of conducting a self-examination of your own biases. When we're looking at cultural knowledge, it's the process of the healthcare professional to seek to obtain sound educational base for cultural diversity. The cultural desire is the motivation for the healthcare professional to want to engage and become a part of the process of becoming culturally aware and knowledgeable for the sake of the patient. And the cultural skill is the ability to conduct the cultural assessments to be able to accurately work with the culturally based physical assessment. So when we're looking at patient-provider communication, a lot of times we want to get away from all the time the paternalistic approach and taking the approach of including the patient, educate them so that they can be a part of the decision making. When we look at cultural competence, according to the Office of Minority Health, the culture refers to the integrated pattern of human behavior that includes language, thought, communication, and beliefs. And when we're looking at competence, it implies having the capacity to function effectively as an individual or organization with the cultural beliefs, behaviors, and the needs presented for the community. So cultural influences your health behavior and the patient's preferences for treatment. So the clinician should also remain alert of these differences of the given cultures. And I also include the veteran culture because that is a culture within itself. You have to understand the patient's sometimes lack of trust or, different experiences that the patient has when they're coming into for your dental procedure. So it's important to explore the patient's attitude, obtain consent and decision making early when you start your clinical relationship with these patients. So when you consider becoming cultural competent, what are 5 elements that you may want to consider? When you're walking into the room, are you identifying your own cultural beliefs? Can you define your own personal culture? Are you aware of your personal biases and assumptions about people with different values than yours? Or in this case, a different age? Are you looking at them, as Dr. Smith spoke earlier, as their age? Starting with a level of ageism, considering that they may not need this. You cannot make the decision for the patients. And you want to challenge yourself to identify your own values. Sometimes we look at this from the AGS, determine this as your doorway thoughts. What are your thoughts before you enter the room and actually communicate with the patient? You may make considerations just by looking at the healthcare and reviewing the charts. Are you making preliminary thoughts about the patient, or are you actually taking the patient as they are when you come in? The American Geriatrics Society has coined this as doorway thought. And then finally, we'll transition into what is the importance of the interdisciplinary team. So when we're looking at interdisciplinary versus multidisciplinary, the interdisciplinary is a collaborative care plan for patients and innovations, whereas a multidisciplinary care does not emphasize an integrated approach. So a quote from the American Geriatrics Society, um, older adults may benefit significantly from interdisciplinary approaches to care, as geriatric patients are more likely to have multiple medical comorbidities, physical and cognitive impairment. So when we're looking at some of these core components for interprofessional collaboration, it's important to consider your role, your ethical values, your interprofessional teamwork, and interprofessional communication. And this was termed from the IPAC Interprofessional Education Collaborative. So when you're looking at your values and ethics, are you working with individuals of another profession to maintain a climate of mutual respect and shared values? When we're looking at the roles and responsibilities, you want to use your knowledge of your own role so that you can help other professionals appropriately assess and address the healthcare needs for the patient. When you're looking for your interprofessional communication, you want to communicate with the patient, the families, and their community professionals so that you're have a responsive manner to support the teams. And finally, when you're looking at the teams or teamwork, you want to apply a relationship building value principles for team dynamics when you're working on behalf of the patient. So when we look at an interdisciplinary team, and this varies from facility to facility, whether you're working in a hospital setting, like a VA setting, a PACE program. There's several different models of care, but in whole, when you're encompassing the interdisciplinary team, you're looking at the social worker, the physician, the dentist, the pharmacist, the physical therapist, occupational therapist, speech and language pathologist, the nurse practitioner, dietitian, psychologist, and of course, the family member or the healthcare proxy for that patient. So for patients that may be older, some of the common issues or geriatric syndromes that a patient may have, a geriatric patient may have that may benefit from interprofessional collaboration. Patients that have dysphagia, you may need to collaborate with the oral speech and language pathologist. Patients that may be experiencing chemotherapy and have the spontaneous mucositis, you're working with the physician or the orthologist. You're working with the nurse practitioners to kind of make sure that you're helping to keep the patient comfortable. For patients that have compromised manual dexterity, an example would be working with the occupational therapist. For those patients that may have some rheumatoid arthritis, you may be able to get adaptive utensils for the patient, or even electrical toothbrush. Some of the adaptive oral care, um, oral care needs like a toothbrush. They may add a sort of added this picture, but usually like a tennis ball or something for those patients to be able to hold if they're not able to hold smaller objects. And then, of course, patients that have diabetes, you want to kind of correlate to make sure that you're working with them to maintain their periodontal and reduce the inflammatory. So when you consider geriatric syndromes, the three that really stand out that are associated with oral health is frailty, those patients that are frail. And this is the main need for geriatric care when it comes to older adults, because of course, geriatric care encompasses not necessarily the patient's chronological age, but their functional age. So when we're looking at an older adult, are they independent and able to move around? Because you can have an independent 90-year-old adult and a dependent 70-year-old adult or a frail 60-year-old. So you can't necessarily go by the patient's age, but you want to go by their functional status. When we're looking at dementia, you want to make sure that you're encompassing the patient's behavioral issues and also aiding them in maintaining their oral health. And the same thing as it relates to dysphagia and to reduce the risk of aspiration failure. So how can we improve geriatric dental care across the board? It's important, in summary, to identify the unique needs, to improve access to care, promote caregiver education so that those patients that are dependent, the people that are caring for them, understand how important the oral health care needs are, and they can serve as an advocate for those patients. And also the interdisciplinary collaboration to provide patient-centered care to improve the overall health equity for these patients. You want to look at community-based programs, integrated medical and dental care, make sure that you're encompassing the cultural competence as well as the interdisciplinary collaboration to push the policy and advocacy initiatives to create health equity for this population. Some of the model of cares for geriatric patients is, of course, the comprehensive dental clinics. Some patients that are not able to transfer their mobile dental clinics to actually go to some of the long-term senior living communities. There's teledentistry for some homebound seniors. The need to increase geriatric dental training programs is imperative so that we are able to teach those who are going forward um, the needs of this growing population. And then, in summary, the community partnerships for dental outreaches are another way to access dental care for some of these underserved populations. And when we're looking at policy initiatives, of course, we know that the need to expand Medicaid for dental services, to increase the reimbursements for geriatric care, implement incentives for dentists to serve the geriatric patients, and also promote the geriatric dental workforce development programs. So when we're looking at the future of geriatric dentistry, we want to understand that the older adult population continues to grow. They're one of the fastest growing populations, and there's an urgent need to continue to research education and changes in policy that are essential to addressing these needs for this population and demographic. Innovative models of care, as we spoke about earlier, ensure that older adults have access to this health equity and high quality comprehensive dental services that support their overall quality of life. And then in summary, I just want to leave with this quotation. It's a little dated, but I think it's timely in the fact that we are speaking with the educational setting, that there are organizational, political, and ethical and legal problems to be faced. But it is certain that the coming process of reexamination and responsibility of the academic health centers and other educational institutions will be central in the provision of healthcare can be improved by closer interactions with health professionals in new ways. The education of health professionals together can facilitate the cooperative endeavors so urgently needed in practice for the care in patients. And this is from the Institute of Medicine. Thank you for your time today. Are there any questions?
Awesome. Thank you so much, Dr. Hogue. Any questions in the room or in chat that we can put forward to her? Yeah.
I just have a dumb question. I mean, is geriatric dentistry a specialty, or how do you?
Okay. Yeah. So the question is geriatric dentistry a specialty, or how do you become certified in this lane?
Right. So that's a good question. Unfortunately, currently, we do not have the specialty designation through the American Dental Association. However, our fellowship programs are available. Like I did a fellowship program through the VA, an Advanced Geriatric Fellowship Program. And then there are also fellowship programs throughout the country that just focus on geriatric dentistry. But they have not solidified geriatrics
Sorry,
specialty as of yet.
so you
I
broke up a
believe. Oh, I'm sorry. I just said they have not solidified it as a specialty as of yet. I believe in the coming, as there is more reimbursement and um, coverage for geriatric populations, I believe there will be a push to
So there are there residency programs that have like where there's an emphasis on geriatric dentistry?
Yeah, so there's fellowship programs. So, for instance, in my track, I did a GPR, the general practice residency, and then I did a fellowship with the VA. Um, and that was an additional 3 years where it encompassed research, education, teaching, as well as clinical practice. Um, and that's usually an interdisciplinary fellowship. So I worked with the physicians and the pharmacists and treatment for the patients. But there are other programs out there that are like certification.
Awesome. There's also a question from the chat. Can you talk a bit about teledentistry and how it improves access for the
I'm
geriatric
sorry. Okay. What was the question?
Can you talk a bit about teledentistry and improving access for geriatric dentistry? Have you come across any programs or interventions related to teledentistry?
Yes, so I believe it's more so state to state because some states do not reimburse for teledentistry, but for models such as like the VA or other healthcare systems that work with patients from rural areas, they do have those models for the medical setting, and then a lot of the people join in with the dental setting. So I know in some areas you're not necessarily doing the treatment, but it's more so the assessment for the patient through teledentistry so that you're able to do the assessment and know if the patient needs to come in for those that are frail patients.
Awesome. Thank you.
Mhm.
Any other questions in the room or via the chat? All right. Well, thank you so much, Dr. Hogue. I'm so sorry you weren't feeling the best, but we appreciate you pushing through and still speaking with us today.
Yes, thank you so much for having me. My pleasure.
All right. Take care.
Thank you.